So I can't tell you how excited I am about this panel. I've said that every panel though, haven't I? Yeah, sorry. So we have three wonderful colleagues here. Lisa Harrison is representing the Health Department Network, and we're really pleased to have her here. She is, okay, this is an aside, she is pitch hitting for the original person, but we got the right person. Sometimes the universe will throw you a nice benefit and things work out the way they should. This was a case of Lisa was so supposed to be a part of this effort. So we're so glad you're here, Lisa. Lynn Perrin represents the Community Care of North Carolina Network, and we're really pleased to have her here. Lynn's been part of this design. I also want to give Anna Boone, wherever she is, I think she may be outside, there you are, a shout out. Anna is with the CCNC state level network, and she has helped coordinate Lynn's participation, so thank you. And then we have Marty Wolf with I always get this wrong, I'm sorry, the Federally Qualified Health Centers. And Marty, I have to say, just as a note, Marty came in day one, I'm like, I know your face from the website. And we started talking, and she stayed for both of the full 2 days of the Institute. So I just want to give Marty, you a shout out for really becoming a part of this effort. Very exciting. So with that, I believe you all are going to be self-clicking, but do you have your clicker? Yeah, where's your, uh-oh. Excuse me, embarrassing technical point. There we go. Sorry, guys. So Marty's going to start us off, and then they're going to go down the list. So thank you all so much.
Okay, so I'm cold-natured. That's why my jacket's on. I'm sorry. And two additional notes. This is usually the death spot, the after lunch. Your tummies are full. And I unfortunately didn't think about that and bring one of my koosh balls to throw at you when I see the nodding head. So, however, I'm not afraid to walk through the crowd. And the other thing is, you notice the kudos she gave to Lisa about being the right person. Here you've drawn the short straw. So with that being said, let's see if I click a button and things work. There we go. So I'm going to talk to you about the Federally Qualified Health Centers. The aside is I work at the association, the North Carolina Community Health Center Association. I am the clinical programs director there, which means I try to do training and technical assistance around anything that smells clinical, which of course ends me up with OSHA and HIPAA and standards of care and evidence-based medicine, and we have things called FTCA, Federal Tort Claims, which is malpractice. And so anything that might affect a provider or care delivery ends up in my lap, and recently, in the last couple of years, has included now informatics and analytics. So I've learned a heck of a lot in the last few years about computers and programming and junk that I never thought I would ever even know how to say the words. So that's me, and I'm here representing our health centers. So we're going to look mostly at what the health centers are. These are the people that you really want to know, because these are the ones you would be contacting for care for your folks. So I'm going to talk a little bit about the background so you know what we're about, and then give you a little bit of information about where we are in the state so that you can find us and talk about what we can do. I will try to keep the jargon to a minimum. I have learned so much from you in the last day or so. It's been a real honor for me to be here and grok some knowledge that I had no idea. So I'm really pleased to have learned all the things that I've had. So I'll try not to drown you with some more terms that you might not understand. All right, so the health movement is 50 years old. We're celebrating our 50th anniversary year. We started with the civil rights movement back in the 60s, and this was part of the war on poverty. Somebody realized that many years ago that there really was a thing called social determinants of health, that if you didn't have good living conditions and good food and all of those other things, that you weren't going to be healthy either. And if you didn't have insurance and some other good stuff, there was also no access to care. So these first pilots went out first in Boston and in Bayou, Mississippi. So those are some of our starting points. The basis of it is community-oriented primary care. I was appreciating what Renee said. Just like the federal grant that she was talking about, we write federal grants as well, and they're 200-page documents where you really have to air all your laundry. We also are community-based with and I'll get into the governance about the members and who tells us what to do. But it is based on community members. shaping the delivery of care. They shape the services, the hours, and those sorts of things based on the federal guidelines. We are under the Bureau of Primary Health Care, which is located in the Health Resources and Services Administration, which of course is under DHHS at the national level. So we all kind of end up being in the same pot, but thanks to the siloing that we're used to, a lot of us don't know each other exists. Ta-da! Okay, I can sit down, right? The primary mission, and you can see there's our little HRSA and our the other HHS symbol. This is one of HRSA's slides for us. The mission is to improve the health of the nation's underserved communities and vulnerable populations by assuring access to comprehensive, culturally competent, quality primary health care. And I'm going to tell you what each of those things means very specifically, because we are not meant to be last resource, you can't go anywhere else, none of that. We deliver care at least as good and often many times better than a lot of private practices when you start looking at data. So, FQHCs, federally qualified health centers. You may also hear people say community health centers. Those two words are basically interchangeable. So anybody says FQHC or CHC, they're talking about these organizations. The health centers get a federal grant to support their care for uninsured, underinsured, people who have access issues. This is under the Public Health Service Act. It's a Section 330. So people are saying, if you hear, oh, they have a 330 grant. This is one of those 330 grants. There's an alphabet soup that goes under 330. And I can't keep them straight, and it doesn't matter to any of us, except there's different definitions. So you can be a health center and a community health center and an FQHC, but your definition of who you're going to serve in the federal grant you write, where you have to document the need and who you're talking about, you might be a community health center, which just means our community at large. You might have picked migrant health centers. So we have health centers that out in the Asheville-Hendersonville area, there's Blue Ridge Community Health Services, which has a large migrant farm worker population. Down in Greene County is another one that has a large migrant population. So part of their funding includes migrant health centers. So they are specifically addressing the people who come and go and do the farm work in the areas. There's a specific health care for the homeless. So if you can also target the people who have homeless. And unlike what we were hearing with HUD, doubling up is a definition of homeless for this federal program. But just like HUD, we have our own alphabet soup of definitions there too. And then there's public housing for primary care. These are kind of the four primary ones that we see. There's black lung and some other ones that just aren't as common across the nation. And right now we really don't have a public housing grantee, but those folks will actually put a health center and locate in one of those development areas, and that's their population. It's to and be in a low-income residential area and provide care to that specific population. There's also federally qualified health center lookalikes. You may just hear them abbreviated as lookalikes. It's a CMS designation, Centers for Medicare and Medicaid. So they have to do everything that the health centers have to do, but they do not receive the funding. And once I talk to you about what we have to do to be health centers, you're going to wonder why the heck they would do that. So to be a health center, you can't just plop one down anywhere you feel like it. You must be in a medically underserved area, MUA. You must serve a medically underserved population, an MUP. And you have to also be in what's called a HPSA, Health Professional Shortage Area. So that means there's not much access to care for you there. You are governed by a community board. 51% or better have to be users of the health center. That doesn't mean I just came in and got my blood pressure checked and you can call me a user. I have to be seeking my regular primary care there. Your composition of your board must look like what the population looks like. So if they're migrant farm workers, 51% of your board should be migrant farm workers. If you have a young urban population of childbearing women, 51% better be mirroring that. So by all of those things that we define cultural competency, you have to mirror that in your board composition. You have to do comprehensive primary health care and enabling services, and I'm going to show you a little bit later what a definition of those things are so that you get a real sense of that. We do provide services regardless of whether you're a homeless health care or community health center or migrant, whatever. We provide services to all regardless of ability to pay. One of the regulations is that we have sliding fee scales for our patients. So based on your income, what you pay could actually slide down to zero. So if you're uninsured, and I've, hearing some of the incomes I'm hearing from people who get $700 a month and they have to do what? Buy groceries and get a house and, some expensive drugs and those sorts of things. Healthcare is often the bottom because you can't afford it. I've got to eat first, before. What good does it do me to starve to death? I can't go to the doctor and say I'm starving to death because they can't give me a medicine for that. And there's a whole bunch of other performance and accountability requirements that we're going to look at. Just to make a note, we are not rural health centers. That's kind of a different thing. There's a federal one and there's state ones, so we're not rural health centers. Some may have both designations, but a federally qualified health center is not the same as a rural health center. We are not free clinics. Free clinics cannot bill under federal legislation. FQHCs must bill. Doesn't mean they're going to collect, but they must bill. So they can't bill differently. Yes, we have a sliding fee scale and you pay differently, but we can't say because you're who you are or you're in our target population, your bill's $5 and, oh, I know you have a good job at the state, so you're going to pay $20. I can't do that. Everybody's got to be billed the same, whether it's written off or not. Have to be public or private, tax-exempt nonprofits. Have to provide those comprehensive services across the lifespan. They can be rural or urban. I don't know what that little, I obviously had a brain fart there, but there's no different governance requirements. But for us, we have different governance requirements. So we recently got some new access points awarded by the feds. And up until now, my story has been, there have been no health departments that had an FQHC grant because of state governance of the health departments being in conflict with the federal governance requirements. And this round of new access points that was just awarded, Craven County got one of those awards. So we're now going to be working with an FQHC in a health department. So I'm interested to see how this will work because, again, it's always been a governance issue. So we can be rural or urban, but we have different governance requirements than the rural health centers, the free clinics, and health departments. Okay, so our footprint, this is kind of us. We have, since the beginning, been a one-stop. Sorry, English is really hard for me. Never mind, it's my native language. And if I do some spoonerisms, I have said some really ugly things and not even known I'd said them because the letters got mixed up. So anyway, so we consider ourselves the original healthcare home because we tried to put all of these things under one roof to begin with way back 50 years ago when somebody went, oh, war on poverty, oh, social determinants of health, but that wasn't the fancy words they used. So we have pharmacy, we have outreach, we have enabling, we have been trying to integrate behavioral health since 50 years ago, and dental and primary care, trying to put all those things in one place so that if you can get there in the first place, we can take care of it all while you're in the house. So you don't have to come back. This is the most recent map. It is missing all of the new access points that were just awarded because, I can't run this map program and the person wasn't there. So this is a picture of them, and there's like lots. It's not that your eyes are blurry after lunch. You're not having a sugar coma. Some of these locations are that close that it looks like there's blip, 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 blip. So what we have is, at the time I wrote the presentation, we had 34 organizations operating almost 180 clinic sites, delivery sites across the state. So you can see where those are. And now we've always had trouble reaching out into the West because, like I said, when I go over the requirements, you're going to say, why would anybody do this in their right mind? But people are we're starting to get more sites to the West now. So there's where we are. If you go to ncchca.org, which is our website, you will find at the bottom of the home page, there's a find a CHC, and then you can click and download a list, and it will give you all of the sites and separates out some of the services. It'll tell you if they have OB or if they have dental or some of those other things that you may need on site. Just an FYI, because a lot of people think they get federal money must be a free ticket. They don't need any help from us. Just so you can see, in North Carolina, 47% of our patients on average are uninsured. We have health centers that go as high as 95% of their patient population is uninsured, so there's others clearly that have a much better payer mix. Nationally, only 35% of health center patients are uninsured. So you can see that we have a heavy burden of uninsured patients in our state. For us, Medicaid is 25%. Nationally, Medicaid is a much more important payer. You know, you can go with all kinds of reasons for that. My favorite reason is that Medicaid pays pretty good in North Carolina, so private payers are more willing to take it than is the case in other states. So that's my story, and I'm sticking to it. I'm sorry, these are kind of dark. I tried to do the right thing. I read those directions for making my slides visual, and I'm just clearly impaired with that too. Medicare is only 14%, or it's 14% in our state, 8% here. So just some idea of what kind of money we get in, and knowing that the federal grant isn't a free ride to do what you darn well want to do. It's not a very big part. In our state, this is a 2013 data. We do this thing called UDS. It's a Universal Data System. Every year we send in these numbers to the feds. It's this huge thing. But the important ones are we served almost 500,000 patients last year. You can see the mix that we had with the illnesses. A lot of people have hypertension, diabetes, and HIV. So we even have, some of our centers have Ryan White as well, so they're doing HIV care. Do we do quality care? Yes, we do. So this is some of the more of the measures that we follow. The community health centers is the dark bar, and the lighter bar is the Healthy People 2020 target. So you can see how close we are, and in some cases exceeding Healthy People 2020 healthcare goals. So yeah, we're doing pretty good with the kinds of care we give. Not everybody does prenatal and low birth and stuff, but the centers that are doing a pretty good job. And that's one of those ones that the lower the number is, the better it is, as opposed to a bigger number. So I just wanted to point out to you, there are the new access points, give a nod to them. Cabarrus, these are existing ones. Cabarrus in Concord, Goshen, which has a main office in Face, and they have like 26 sites or something. Got another one, Southside United in Winston-Salem. Tri-County, which is currently known as Comwell now, in Newton Grove, and they're kind of in the Harnett, they're done kind of down in that area. Western North Carolina, which is a big HIV site, they're in Asheville. And here are the new guys. Charlotte Community Health Clinic has been a free clinic for years and years and years, and now they're one of our new grantees. There's the Craven County government, so the health department, and then we are welcoming Mayheck in Asheville to our family. I made some friends from those folks while I've been here today. So there were 8 awards in this newest round, when we'll be adding 32,000 patients to our population served in health centers across our state. This brought an additional $6 million into our state of money. So, you know, one of the things that health centers like to brag about is, yeah, we give health care, but we also bring jobs, because when you put a health center somewhere, you need doctors, nurses, front desk, medical records, those kinds of things. So there you are, quick facts. There we are again, 34 health centers. We're in approximately 66 counties. We don't define service area by county, so I know a lot of you do, so there it is, but county is not a restriction for us. Almost 180 sites, 450,000, and the statistics based on our employment of who we employ and how much they're paid, we are giving $359 million in economic impact to our state. Just want to go over these requirements. I don't want to bore you, send you to tears, make you cry, and beg for me to step down. But when you write the federal grant, these are all the things you have to talk about, and these are the things you're required to do. You have to demonstrate and document needs. So that MUA, HPSA thing that I talked about way back at the beginning, you have to show that you have a population that needs you to be there, that there's some patients for you to take care of. You have to provide these services that we're going to look at. You have to have enough staff to do it, so you can't just throw it in there and, you know, put one housekeeper in there and say you're giving health care. You have to provide accessible hours of operation and location. Again, that's determined by your board, what's accessible to your population. You have a population that could be working poor, so people who work 8 to 5 or whatever it is, field workers, they can't take a day off because they don't have health insurance, and they sure don't have a paid day off. They're not coming in during office hours, so what are you doing to get those people into care? You have to provide after-hours coverage. Doesn't mean you have to be open or you have to be the one answering the phone, but you have to have some mechanism that people can access care. And we don't mean go to the ER, and we don't mean go to the urgent care. We mean talk to your primary care provider or whoever's on call for that person. have to have admitting privileges or some other arrangements for continuity of care. Admitting privileges are becoming less common because what hospitalists now are taking over that job. So there's new ways, but still we have to have ways for the patients to be in the hospital and taken care of as needed. We have the sliding fee scale, clearly ongoing quality improvement programs. You have to have a competent, fully staffed management team, so somebody's running the ship and knows what's going on. If you're contracting out services, even if you're building something onto your building, you have oversight and authority over those contracts to make sure everybody's doing the same thing. They're all federally compliant. I don't know if you ever heard of the federal debarment list where you can get kicked off of being able to get federal dollars. Those kinds of things you have to follow. You have to have collaborative relationships with other providers. Lynn's here from Gaston. We have a health center and a health department located in the same building. People don't know when they move between services. They just think they're going to the doctor's office and they're getting their care. That's perfect. That's exactly what we want. But also being able to send somebody out to the GI or the cardiologist or whatever. People don't want to see no stinking uninsured patients, do they? So how do you get them into care? What kind of things can you do to get people the care that they need? So we have, it used to be a handshake was good enough, but the feds are getting now we have to have written contracts, memorandums of understanding. And we have safe harbor, so we don't have trouble with Stark and those other guys. So we can say, if you will take our uninsured patients who need a colonoscopy, meaning we have tested them already, we know that they have blood in their stool, we'll send you our insured patients who want a colonoscopy and who can pay you. So that's safe harbor, because otherwise that's illegal. You can't do that kind of stuff. But in a health center you can, because it's called safe harbor. It's how you make arrangements for that large number of uninsured patients. We have to maintain financial management, so just like anybody else, we get GAA audits, and the Office of the Inspector General can come by and smack us on the fingers, all kinds of stuff. And we have to be able to collect and do the reimbursement stuff. So as you can see, that's part of our stuff. Have to have a budget, all this good stuff. There's that governing board again, the board composition, no conflict of interest, blah, blah, blah. Okay, I do want to take a look at these primary care. This is what's considered primary care for us. Think about what you get when you go to your doctor. Okay, this is what we have to do as a primary care. Cradle to grave, anything you need, we have to be able to figure out how to get you that care. So that's our definition of comprehensive primary care. So it also includes, you know, having those babies or not having those babies, if that's what you want, getting the baby taken care of. We do a lot of immunizations. All of those appropriate age-appropriate screenings that are required. We have to be able to get your labs, your radiology. Most of our health centers have an on-site pharmacy. If not, they have a 340B contract pharmacy out in the community. That means 340B pharmacy allows us to have access to drugs at a much lower price. You can't just send your person to a health center because we have a 340B. It must be a health center patient. That's one of the caveats for accessing a lot of the things we do, is that the federal government requires that these are our patients. So you can't just send somebody in like you would send them to Walmart or CVS or something like that. It has to be one of our patients. But once they are, they have access to this great cheapo pharmacy service, which also will have sliding fee scale. We have about a third and closer to a half now have on-site dental as well. So they're doing full scope of dental work. Some of them even are doing orthodontics and the dental implants and that kind of stuff, which is pretty impressive given that they're working with uninsured populations, many of whom are people who can't even afford to go get their own pair of dentures when they need them. So we have enabling services, which are those things like getting people transportation, getting them vouchers for things. We have the many of them have the social workers to help with some of the, and clearly I didn't know what you guys were doing, so you know, they're doing what you're doing out there. We have to handle referrals. We have access to substance abuse and mental health. We have a couple of health centers that even are as deeply embedded with this as having residential substance abuse care. So depending on what you need, you can look and see if those are available. Access, of course, to emergency and emergency services, even emergency dental. Yes, we're trying to keep people out of the ER for bad tooth care because they haven't been able to afford a dentist either. And 24/7 access to care. So we may not be open 24/7, but we have mechanisms for you to hopefully see your primary care provider. All right, so all of that pain in the butt stuff that we have to do, this is why we do it. You get the Section 330 grant if you're federally funded. An average award is $650,000. There's a per patient. There's all kinds of calculations that the government goes into it. So if you're serving a smaller bunch, you're not going to get that much. You have to be serving a pretty significant population to get that large of a grant. We get medical malpractice under the FTCA. So it's medical malpractice, and to do that, you have to prove your quality program, you have to prove risk management. There's all kinds of documentation you have to submit to get your FTCA. And our health centers have this thing called scope of service. And so anything that's in your scope of service, you can do, it's covered under the medical malpractice. However, if you do something that's not in your scope, you find yourself not covered by the medical malpractice. And that can be something as simple as doing a health fair. If you didn't write in your scope to the federal government that you might be doing health fairs, doing blood pressures and stuff, and you squeeze somebody's arm too hard and they decide to sue you because you had a bruise and you didn't have that in your scope, then that's your problem and not the federal government. Otherwise, FTCA, if somebody sues for something in scope, the federal government steps in and says, you're suing us, you're not suing the health center, you're not suing that provider, and they deal with it, which is pretty nice. But they've also gotten to the point where now they're saying, if they think somebody's a problem with medical malpractice, they're removing them from FTCA. So providers, it's not just, again, it's not just a blanket, here you go practice your crappy medicine and, no, you can't do that. Because they're going to take you off FTCA, you're going to get on federal debarment, you're going to be out the door. Historically, we've had some enhanced reimbursement with Medicare, Medicaid, some of these things that I really can't explain, they just happen. And now these are all changing, so who knows, and the 340B and some federal grants. So there you go, there's some big resources for you to look at, and there's me. I'm happy to answer questions, hunt me down like a dog, happy to refer you, hook you up, whatever it is you need. Thank you very much.
Just in the name of time, we're going to hold questions till the end, but we do encourage you to put your questions on today's meet as well, and we'll work to get answers for you that way as well.
Where are you, Trish?
I'm right here. It's the voice from
I'm delighted to be here. There's some familiar faces. It's been a long time since I've been back in this area, and I do come to Raleigh a lot, but I'm mostly going to Community Care of North Carolina for my meetings. I've spent a number of years with the Department of Health and Human Services, so I know about money fall as a person. I was at Medicaid when it was just a glimmer in the federal government's eye, and I'm delighted to see how much it's progressed. And I want to thank you all because I know what you're doing is not easy to do. Coordinating a lot of different community resources to transition somebody out of a facility is hard work. And it takes a lot of creativity, and so thank you for all you're doing. I'm going to talk very quickly because I think that Marty has covered a lot of what a medical home is, the FQHCs throughout the state are important medical homes, and they are a part of Community Care of North Carolina. But again, a primary care medical home is not a building. It's a place where someone can get comprehensive care and get their continuity of care ensured. And this is going to be important for people coming out of a facility where they've had maybe a facility medical director looking after their care. Now they're coming into the community. They need to be linked to a medical home. Medical homes are designed around individual needs. They help reduce the fragmentation of that physical care, and they try to look at behavioral health needs too. We are working with our primary care docs throughout the state to try to encourage them and help them and educate them in identifying behavioral health needs. So you'll probably hear more about that too. They all use evidence-based practices and try to meet quality goals. They have a whole person orientation, and they promote the quality of care and better use of our medical resources. Everybody needs a primary care medical home. Now, I'm one of those that grew up in a family of doctors. I never had a medical home. I always called mom or dad or brother, But you know, now that I'm getting older, I have found my primary care medical doctor, and it is so important because it keeps me from having to go to the emergency room. It keeps me on track with all the screenings that I need, and it keeps me healthy. So when transitioning somebody into the community, you're going to want to make sure that that individual, and most of them are Medicaid patients, I understand, you're going to want to make sure that they select their medical home, whether it's an FQHC or a private primary care provider in the state. And patients should be selecting a provider, a medical home provider, near where they live. Not where their Medicaid card says they are, it's where they're going to be. And the vehicle for linking Medicaid patients to a primary care physician in North Carolina is called Carolina Access 2. Okay? Carolina Access 2. Are you all familiar with that? Am I preaching to the choir? Okay, well that's important to know. And when you go to social services, somebody that you talk to may not know what Carolina Access 2 is. You will know now. To link your patients to a community primary care medical home, you have to get them enrolled in Carolina Access 2. And be sure that you get an appointment established for them before they get sick. Now, the reason Carolina Access 2 is so important for a Medicaid recipients is because they're not just getting a primary care medical home. They have available to them, if needed, an entire healthcare team that is through the regional community care networks. So if they have, and most of your patients probably do have a chronic illness, whether it's diabetes, obesity, other respiratory problems, you're going to want to make sure that they get into their medical home, get it checked, and that they have a medical team, a healthcare team assigned to them. There are 14 regional organizations in the state they are part of Community Care of North Carolina. They all have different names. I represent Community Health Partners, and I serve 2 counties in Gaston and Lincoln County. But my sister networks are all over the state. We are statewide. There are over 6,000 primary care medical practitioners that are part of Community Care of North Carolina. And they work with each of these regional programs. So it's really important that you understand how this works. Each regional network, Community Care of North Carolina network, has care managers, nurse care managers, social workers, pharmacists. Boy, that didn't come out right, did it? I'm sorry about that. Underneath that it says psychiatrist. We all have a psychiatrist under contract or full-time with the network, depending on the size of the network. Medical director, behavioral health coordinators, and patient care coordinators. This is the entire healthcare team that, again, if it's needed by your individual that you're working with, it is there for you. And we all work together. What we are doing in Community Health Partners, we have worked with our team, and is anybody here from Gaston and Lincoln County? Okay. We're working with you to do that transition so that we are going in, it's my understanding, my behavioral health coordinator is telling me this, that we're going to go in and have the nurse do a comprehensive assessment, do that medication review and reconciliation, that's where our pharmacy staff comes in, do any patient education that's needed around any chronic illnesses. We're going to identify what other community services are needed and help link them to those services, and we will follow that patient for 30 days until we know they're safe and stabilized, and then we'll go on to other patients. Now, there are 1.54 million people enrolled in Carolina Access 2, Community Care of North Carolina. okay? We only have 600 care managers. So we have a very set structure on how long we stay with the patient, but we will stay as long as we are needed. Here's our website, Community Care of North Carolina. Go to that website to look up where your regional network is. If you haven't already, I encourage you to be working through your LME MCO, I guess, is your main contact, to work out a transition and be part of that so that we're part of that transition process for your, we call them patients, for your client. But anyway, we look forward to doing this with you. I think it's an exciting endeavor. I know you've been very successful on what you've done in the past. But again, thank you for what you do. It is complicated, and we are here to help you. Thank you.
Just as a couple of points. First of all, Linda was telling me a lot of the history you had with our predecessor program called the Nursing Home Transitions Program. And so just as we just want to recognize the contribution you have made over the years to this activity. So just to highlight that. Yeah, absolutely. But also wanted to clarify that if you have it's certainly we have lots of people who are transitioning people outside the LME MCOs, and so if you have questions for Lynn and from any of the populations, make sure you hold them in or put them on the website. So we'll ask them at the end. So Lisa, thank you so much.
Yes, thank you. Well, my slide set is going to go through a little bit more around what a local health department is and does as far as my perspective being a local health director, but I'm going to jump off from there in a few points so that we focus a little bit more on the transitional care pieces, which is why we're here today together. And to start, it's been fun already getting to reconnect with Marty and learn a little bit more about Lynn. We have literal and figurative connections across family members, friends, and agencies, and just like it should work in North Carolina, right? So one of the things that I'm most passionate about, aside from public health and the public health workforce and the work that we do as dedicated public servants across every county in this state, is also a penchant for rural health. So how many people in the room consider themselves serving a rural area? Great, thanks. And certainly across the rural-urban continuum, there are similar things that we have to connect resources for people's needs. And there are a lot of things that are the same across rural and urban areas. But there's certain things that also have a little extra nuance when it comes to the infrastructure and the ability to connect the resources and the number of resources available across different communities. So a lot of the perspective I'm going to bring today when I talk to you goes beyond just a local health department. So I've been a local health director now for 3 years, but in public health in North Carolina for 20 years. And have done a lot of training, a lot of educating, a lot of connecting of those resources to all the 85 health departments and the staff members in our state. So we have 100 counties and we have a building of a local health department in every single one of those counties. Some larger counties have more than one building. And I happen to be the director of a 2-county district. So the reason there are 85 local health departments in North Carolina is because there are a few of us that are responsible across rural Tier 1 counties to do more than just one jurisdiction and be in charge of all of the things that we're mandated to do by North Carolina general statute to carry out in public health. So my signature goes on every birth certificate and every death certificate across 2 counties. I have a colleague and friend in the northeast corner in those 7 counties up there where all those little finger counties are, Pasquotank, Perquimans, Currituck, Camden, that area. He's the health director over 7 counties. So we try to have some economies of scale in the rural Tier 1 areas where we're connecting the dots with administration and the actual boots on the ground public health going on. So what is it that we really do in health departments? We certainly work with a lot of partners. We work with our local FQHCs when we have them. We work with our Community Care of North Carolina partners. But one of the things that distinguishes local public health from other areas is that we do something called a community health assessment every 4 years in North Carolina. And we're starting now with new IRS rules to be able to do that with more broad partners than have been at the table before. And hospitals are particularly interested, especially not-for-profit hospitals, in more population health focus areas and priorities that community health assessments do. So in my 2 counties, these are the 3 priorities our last community health assessment came up with. So for the entire population, we try to focus on these kinds of things. And that makes it hard when you're talking about transitional care and individual care. Sometimes your health department's going to look at the services we provide per member. And sometimes we're more outstretched in a community to look at the population health overall and health in schools and reproductive health and pregnancy outcomes and chronic disease and related issues. So we're at the bottom where we deal with a lot of the socioeconomic factors. This is a pyramid that shows you how we have health impact. So where a lot of the things we are doing together to take care of patients are at the tippy top, where you do the clinical interventions and the counseling and the education. We try to also look at the base of that pyramid in every step along the way. We have a mission and purpose to keep everybody healthy, to protect and promote their health. So you can see how we're a little bit more broad-based than some other clinical pieces of things. But we do also make sure that we're paying attention to all the communicable disease issues in a community. Most of us in health departments do carry out child health and maternal health, environmental health, nutrition and WIC, and then, like I mentioned, vital records and community statistics. But I think the thing that's most connected to the work that you do and that you're here to learn more about are our transitional care models we're trying to become more involved with. Not every local health department has home health. In my health department, we do still have home health because we serve a primarily rural, poor community. And the numbers or the volume of patients is not so great that a lot of private industries have not come in to compete and want that business. We also serve a tremendous number of uninsured or Medicaid patient population. So those private for-profit companies aren't clamoring to come compete with us in that regard either. But what we do have is an opportunity across my 2 counties to work with 2 different hospitals and a lot of other private primary care agencies to be the place where we do a lot of case management for individuals and home care. So home health is an interesting thing right now. Like everything else in healthcare, it's going through a tremendous amount of flux and unpredictability about how we get reimbursed for the services in the future. The Centers for Medicaid and Medicare are not making it real easy for us to figure all of that out, are they? But in order for a patient to be eligible for home health, they must need skilled nursing care on an intermittent basis, or they might need physical therapy, speech therapy, or occupational therapy, and have a continuing need for one of those therapies. So that's the real general overview. Of course, home health has a lot of really nitty-gritty, detailed regulatory pieces that make us sometimes have to say, well, this patient isn't appropriate for home health care that's reimbursable from Medicare or Medicaid. This person is eligible for more case management care that we do in concert with our Community Care of North Carolina partners. So the nice benefit to coming to a health department run home health agency is that we do have those partnerships within a community, and we do have some flexibility with where a patient needs to be based on the care that's available to them in the area. So again, case management and transitional care is something that home health agencies are trying to get better at doing. There are so many restrictions on what CMS will allow for you to pay for and not pay for that sometimes the no comes out before the maybe let's figure it out comes out. So we're trying to get better at saying, well, let's figure this out. Maybe we can do that. Maybe we can work together with our partners and take care of that particular patient, keep that particular patient out of the hospital. And so now my two hospitals have transitional care individuals who are working specifically to case manage and work with us and call us on a regular basis to help with that. So I want you to just leave my talk knowing that local health departments can be a really creative resource for you. They're a little different in what we provide across the state, but in general, in rural areas, we do have a lot of different types of services that you might not predict. This is just a quick map to show you how we're organized. Districts are the ones that are in color, and I'm in that little middle section, that northern Piedmont section of North Carolina. We have certainly paid attention to all the moves and shifts and are trying to place ourselves in a way that we're doing all of the same kinds of connective services that you're doing in quality improvement and paying attention to big data and making sure that we're always doing evidence-based public health approaches, and you've heard that already on this panel. We're certainly founded with a core of social justice, and so we try to ensure that everyone gets served, no matter their ability to pay. And we're really big into partnering in local stakeholder connections. We're paying attention to this issue you've heard a lot about, I know, about prescription drug abuse, and there are a number of projects and interventions from a community level where we're trying to work through that with our mental health partners and our primary care partners. We just got a new grant recently in our health department to help try to address this issue. And I know there are so many individuals who fall under needing case management and transitional care, who need medical assistance and management of medication in particular. And so that ends up being a really tough thing. So some of our nurses and social workers are getting some extra training to be able to educate for medication management and ensure that we don't have the abuse that we've been seeing recently. So on the left-hand side, you see our mandated services. We are certainly in charge of environmental health, vital records, and communicable disease according to state law. And then on the right-hand side are things that we can either do or we can contract out. Lynn mentioned in Gaston County, they connect a little bit more with their CCNC partners to do some of the right-hand side services. So you can't tell a difference when you walk into the building who you're headed to see, the CCNC people or the health department people, which is a beautiful partnership. We're not quite as lucky where we are in being able to outsource a lot of that. We still do a lot of that. But I know all of these shifts and changes that we're seeing, you never know. So I won't go into the funding. That slide was more for county commissioners to convince them how important it is to get funding locally. I won't bore you with that part of it. I've had enough budget talks recently. I won't belabor that for me or you. It's Friday afternoon. We don't want to talk about money. But this is one of my favorite quotes to say the health of the people is really the foundation upon which all their happiness and all their powers as a state depend. So the advocacy and the connectivity that you all provide for patient-centered, patient-focused care, where that money follows the patient and the resources follow the patient, is truly essential to how powerful we are as a state, how effective we are, how economic development and education fit into the work that you can do when you're healthy in a community. So just think of your local health department as your friend and neighbor. If you don't happen to have one of those individuals that's really great at partnering and is overwhelmed with the work they're doing, feel free to call me. I happen to be the president of the North Carolina Public Health Association this year, so I will find you public health resources. If you don't have that person that you connect with well at a local level, we'll try to find another answer for you, because we too share that dedicated desire to help the patients and to improve the health of our communities. So thank you, and I'll turn it over to Trish for question and answer maybe.
Awesome. Thank you, Lisa. Can we give them all a hand? Yeah, that was good. Good stuff. So I'm going to invite Benjamin to put up the today's meet log, so if there are questions coming up there, we can make sure to answer them. Are there questions for our healthcare panelists? Yes, we're starting to see hands. All right. Coming to you, Megan Robertson.
My question was for Lynn. Specifically, the individuals that I work with are coming out of institutions, so their Medicaid is labeled as long-term care. And in the process of transitioning them out, their Medicaid will be switched over to a point where they can be under Carolina Access. But up until that point, I know in the past CCNC hasn't been able to get involved because they're not labeled as Carolina Access yet. I know that's something that had been identified. I wasn't sure if there was any movement towards getting CC involved prior to them being labeled as Carolina Access.
That may be a Trish answer, because I don't handle Medicaid. We just deal with our patients when they become Carolina Access too.
So Megan has raised, I think, a systemic challenge. Anybody else experiencing that challenge? Yeah. So there are a couple of different initiatives that are happening in different programs. One of the things that the Division of State Operated Health Facilities has done, and Vivian, would you like to speak on this directly, what you all have done? You sure? Okay. So the Division of State Operated Health Facilities, when we started having conversations about this dynamic, they have worked out a direct relationship with the statewide network for their developmental centers folks to be, at least have a point of contact in identifying a primary care provider. The eligibility doesn't turn over officially until the person transitions, but they at least have a point of contact. MFP is starting, thanks to, again, our colleagues within the CCNC network, are starting to pilot some pre-transition care management involvement so that the person can be truly linked with that primary health physician before they transition. And I want to speak, Darlene, can somebody speak to what's going on with TCLI a little bit?
We do with all our consumers that we know that CCNC would be a great resource for them, and just have them call DSS and have them change their Medicaid to Carolina Access, and it goes quite smoothly, and we haven't had any issues with that.
One of the problems may be the different types of facilities that we're transitioning out of. I'm wondering if the adult care homes has a slightly different Medicaid eligibility consideration than the skilled nursing facilities and the ICFs.
Okay, yeah, maybe.
That may be the issue. This is a systemic thing that we at the state are very, very intent on continuing to work on, and I think there's no philosophical disagreement from anybody's part that this is a good thing for us to keep working on. So, good question. Other questions? Other questions? Anything coming up on the feed? What is the difference between Carolina Access and Carolina Access 2?
Carolina Access 1 doesn't have the health team. We call it Carolina Access 2 is the Medicaid program on steroids. You get that whole team assigned to you. You can be in Carolina Access 1, we call that, you still get managed care, you get a primary care doctor, but you don't have the services if you need them from that care manager that goes in and does the in-home visit and does your medication management. So we really encourage folks, if you're able to get into the 2 program.
Any other questions? What? Yeah. Well, I want to thank our panel one more time for you all's time and attention, for good information, critical information.